Hello everyone. First of all, I would like to thank Dr. Swati for including me in her course. Before we get into final points, we have to understand one very important point that is the rexus size. So when we are doing toric IOLs, the rexus size should be below 5.5 millimeters in order to have a very good overlap of the rexus on the optic. This will ensure a good rotational stability. Second important point is that never implant toric IOL in patients who have intraoperative complications like posterior capsular rent or zonal dialysis. So these are the points which I'll be covering. So first thing that you need to ask yourself is the primary reference mark, are they acceptable for you? To give you an example, have a look at this image. Now, if you see this, these are the two marks which are at 180 degrees, but are they exactly the midpoint of the cornea? So if you draw a line connecting these two dots, you will see that the line does not really touch the corneal Purkinje image. So, and divides the cornea into a symmetric smaller superior half and a larger inferior half. So in this scenario, this is not acceptable. So in fact, a line which passes through the Purkinje image, the end of that point will be the 0 degree. So this one has to keep in mind. And on table, one can use that analogy in the form of an iris spatula, and that can be used to kind of draw an imaginary line, trying to find out which are the exact 0 degree marks. Now, this is again confirmed by a digital marking system, that is Varion, and you can clearly see that the 0 degree line is passing through the corneal Purkinje image, and it is way different from the original mark, and it divides the cornea nicely into equal halves. Now, coming to the technique of toric IOL implantation. So this is what I've been following for years together now, where I basically use viscoelastic for implantation of IOL. So part of my lens directly goes in the back, and the remaining part is in the anterior chamber. This gives me an easy access to the area behind the lens to remove the viscoelastic. And once that is done, I kind of rotate the lens with the help of iris irrigating cannula itself, and then gradually nudge the lens, all the part of the lens in the back, and then use this iris dialer to do a fine adjustment so that the lens is dialed into required axis. Now, once that is done, we have to ensure that the anterior chamber does not collapse at any given point. And when you are withdrawing your thing, you basically keep the irrigation on, and you try to hydrate the side ports so that the anterior chamber stability is maintained. So this is how you kind of finish the case, and the lens is well centered, and you can see that it's in good alignment. So when digital marking has of late become popular, and this is now preferred choice if wherever it's available. But can we totally rely on digital marking? The answer is no, and we'll see why. So what I routinely do is, whenever I do any case on digital marking system, we use Varion. We essentially mark the axis at the start of the procedure. So here it was 167 degrees, and we have marked it based on what we got from the Varion thing. And here you can see that the actual axis shifted during the process of surgery by almost 10 degrees, and this can happen because of certain changes that the cornea may undergo and during the procedure. So one has to keep that in mind, and with the rotation of the actual axis, you can actually rotate the lens, and that might lead to an over rotation and misinterpretation. Eventually, the axis came back to 167 degrees, and the surgery went on smoothly. And with regard to a multifocal toric or a trifocal toric, very important to check these two images, which are the first and the fourth Purkinje image. And while doing the final centration, you have to make sure that these two images kind of align in the central most ring of the lens, so that an absolute centered IOL is ensured. Sometimes you can have overshooting of the mark, as in this case, the lens is supposed to be implanted at 20 degrees, and you can see that as we are implanting the lens, it has already overshot. So in this situation, you have to keep rotating the lens in a clockwise manner, and having a part of the lens in the anterior chamber helps in this rotation, and then slowly keep rotating the lens till the point you are onto your desired axis. So it's not very difficult to rotate these lenses in a clockwise manner. And though anti-clockwise rotation is not recommended, but in some cases where the rotation is just probably less than 1 clock hours, one can still do it in certain lenses. Like in this case, it's a Technis Toric, and we are actually, the lens is shot by about a clock hour. And in this situation, we are going to just essentially rotate in anti-clockwise manner to bring the lens back to its axis, and this was how it concluded. So you can see the lens axis is brought back to its level which was intended. And at the conclusion of the surgery, one has to remember these 3 points: that one should never overinflate the anterior chamber, because once the anterior chamber comes back to its normal levels, there is a possibility of rotation of the lens. And of course, you want watertight wounds, because leaking wounds will lead to shallow anterior chamber and again a possibility of rotation. And the third most important point is these patients should be instructed not to move for the next 1 hour. So they should not be discharged early, as we routinely do for other patients. And this evidence has come from this paper which was published in Ophthalmology, which says that the greatest misalignment of toric iol occurs in the first hour post-cataract surgery. So to conclude, I would like to state that understanding and implementing these points during the toric iol implantation will go a long way in ensuring predictable and accurate outcome for our patients.